Good evening, ladies and gentlemen. It is indeed a pleasure to welcome you all for the inauguration of the 28th Annual Academic Sessions of the College of Community Physicians of Sri Lanka and the College Oration for 2023. Ladies and gentlemen, please rise for the ceremonial procession. Please remain standing for the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo 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 Mata. Sundara Sri Karini, Surani Ati Sobhamana Lanka. Ranya Danaya Mekamal Walakulu Piri Jaya Bhumi Ranya. Upper
Thank you, ladies and gentlemen. And once again, whilst welcoming all of you for the inauguration of the 28th Annual Academic Sessions of the College of Community Physicians of Sri Lanka, I would like to cordially invite the following dignitaries for the lighting of the oil lamp. President of the College of Community Physicians of Sri Lanka, Dr. S.M. Arnold. Our chief guest this evening, Dr. Anila Das Bandaranayaka. Our orator this evening, Professor A. Padmeswaran. Representing past presidents of the college, Dr. Nihal Abe Singha. Representing fellows, Dr. Pushpa Jayawardena. Additional Secretary, Medical Services of Ministry of Health, Dr. Sunil Dialvis. Director General of Health Services, Dr. Asila Gunawardena. Dr. Dhammika Roel, representing UNICEF. The Chief Migration Officer of IOM, Dr. Kavru Takahashi. Dr. Nayani Suryarachi, Country Coordinator, Fairmed Foundation, and President-elect, Dr. Shiromi Madhuage, Honorary Secretary of our Council, Dr. Tushani Dabarera, and our Honorary Treasurer, Dr. Atula Lena Patirana. Thank you, ladies and gentlemen. You may be seated. I would now like to invite the following dignitaries to the head table. President of the College of Community Physicians of Sri Lanka, Dr. S.M. Arnold. Chief guest for this evening, Dr. Anila Das Bandaranayaka. Orator for the college oration, Professor A. Padmeswaran. Dr. Tushani Dabrera, Honorary Secretary and Honorary Treasurer of the Council, Dr. Atula Lena Patirana. To commence the proceedings of this evening, I would now like to invite the President of the College of Community Physicians of Sri Lanka, Dr. S.M. Arnold, to address the gathering and welcome you all.
Ayubowan and good evening. Our chief guest tonight, Dr. Anila Das Bandaranayaka, former Assistant Governor of the Central Bank of Sri Lanka. Orator, Professor A. Padmeswaran, Emeritus Professor in Public Health, Faculty of Medicine, University of Kelaniya. Council members, past presidents and fellows of the college, officials of the Ministry of Health, development partners, distinguished ladies and gentlemen. It gives me great pleasure and honor to extend a warm welcome to all of you at this inauguration of the 28th Annual Academic Sessions of the College of Community Physicians of Sri Lanka. The College of Community Physicians of Sri Lanka is the oldest and the first professional body established under a Parliament Act for the public health professionals in Sri Lanka. We started our journey in 1926 as a Society of Medical Officers of Health. Currently, we are having over 600 members working with the view of safeguarding and promoting public health in the country. By looking at the past, we are proud and happy to announce that the past presidents, councils, and memberships have worked to uplift the public health in the country, uplifting the skills of the membership and promoting health policies by advocating at various levels. It all happened in team spirit. This year, the annual academic session is enriched with pre-Congress workshop, college oration, symposia, plenaries, and thematic sessions. We are sure that you will benefit from all of these. I'm most honored to welcome our chief guest tonight, Dr. Anila Dias Bandaranaike, former Assistant Governor of the Central Bank of Sri Lanka, for gracing this occasion. Your presence here today is a great strength to the college. My appreciative welcome goes to Dr. Asela Gunawardana, Director General of Health Services, Deputy Director Generals, Directors, and all other officials from the Ministry of Health. My heartfelt gratitude and appreciative welcome to all the past presidents, fellows, council members, and all the members of the College of Community Physicians of Sri Lanka. I warmly welcome all UN partners. My gracious welcome goes to all special invitees, distinguished guests, and all of you who are gathered here today. Once again, I welcome all of you who have joined the inauguration of the 28th academic sessions of the College of Community Physicians of Sri Lanka. Thank you.
Thank you, sir. We will now take a few moments to see a brief glimpse of the activities carried out by the college in the last few months.
It was a remarkable council year with many planned activities well executed. A lot was done this year. Our activities were focused on many areas including the membership, general public, important public health issues, and improving the quality of the public health services.
The College of Community Physicians is the premier association of public health professionals in Sri Lanka. The college has many objectives. Of those, one of the main objectives is to promote public health in the general population. In addition, the college promotes postgraduate education in community medicine in Sri Lanka. During the current tenure of the council, our activities were focused mainly to achieve the objectives of the college. In order to achieve the objectives, we carried out many activities, including many programs covering many aspects to the membership as well as the public. We were able to successfully achieve our planned activities and achieve the objectives of the college.
Let us have a look at the wonderful work that was finished over the council year. Journal Club. 6 journal clubs featuring significant and timely topics were held. These articles have been presented, critically analysed and thoroughly discussed by our membership. Out of many, a significant journal club was organised by the collaboration with the Sri Lankan College of Endocrinologists and the College of Community Physicians. The Young Community Physicians Forum. The Young Community Physicians Forum served as the forum for community physicians to discuss vital issues relating to both public health and their own profession. Some of the topics that discussed were the impact of economic crisis on our health system, looking after our mind and money amidst the economic crisis, and what you should know about publishing your research findings. Capacity building programs. The CCPSL ran capacity building programs for many health categories that provides public health services. These include workshops on research methodology for public health staff in Kandy district, online courses for MOHs on court procedures, CPD sessions for MOH staff in Western Province, training programs for staff members involved in maternal and child health in Western Province, and supportive supervision of MOH officers in the Western Province.
In conducting activities, the college went beyond Colombo. College reached the periphery or the provincial level. College conducted capacity building programs for public health staff in 20 districts. The college covered the subject areas of migration health, filaria, malaria, STD/AIDS, tuberculosis and health security. We were able to train over 1,000 public health staff in 20 districts. It was a very successful program where the mode of delivery was appreciated by most of the participants.
Once more, the college offered a 13-week community medicine review course to assist candidates preparing for very important MSc Community Medicine screening examination. Public awareness activities. CCPSL carried out an array of public awareness campaigns throughout the council year on current issues that affected the general public. These include webinars, television and radio programs, press conferences, press releases, as well as newspaper articles. Membership activities. For the membership, the college conducted a webinar as a guidance sessions for trainings in community medicines. Again, discussions were conducted by the college to exploring the challenges faced by the trainees in community medicine. Again, the quarterly newspapers were published in the month of November 2022, March 2023 and June 2023. Orations. Dr. F.A. Wickramasinghe oration and Dr. A.V.K.V. De Silva oration were conducted by CCPSL. Social activities. The College of Community Physicians of Sri Lanka proudly presented the CCPSL Talent Show 2023, showcasing the amazing talents of members of CCPSL.
අපරයියගේ ලොකු කොළුවා යුද්ධෙට බැඳිලා කාටත් නොකියා කොළඹින් කසාද බැඳලා මනමාලි කැරොල් කරත්තයක් කියා ගැසෙන්න මුකුළු පාන්න.
The annual cricket encounter of College of Community Physicians and Ceylon College of Physicians were held with the participation of members of both colleges. Collaborative activities with other professional organizations. The CCPSL collaborated with other professional colleges and organizations in doing the activities such as conducting monthly clinical meetings with the Sri Lanka Medical Association. Moreover, a series of training workshops were conducted in collaboration with the College of Palliative Medicine on carrying out systematic reviews for the postgraduate trainees.
The council year was quite successful and productive. Numerous activities have been effectively planned and executed. We have developed a new website containing a brand new interface that includes a wide variety of content with user-friendly navigation with frequent updates. Social networking is currently the finest way to communicate and share knowledge. Every activity was regularly updated and disseminated among our members and the public, utilizing an audience-friendly, unique style on our Facebook and YouTube channels.
As you were already seeing, this was a truly amazing and very productive council year, both academically and non-academically.
Hope you all got a glimpse of the activities that have been taking place over the last year. And whilst congratulating the President and the Council for the wonderful work that has been carried out, I wish them well for the rest of the term. Now it is indeed my pleasure to once again invite to the podium Dr. S.M. Arnold to introduce and read the citation of our chief guest this evening, former Assistant Governor of the Central Bank, Dr. Anila Das Bandaranayake.
Dr. Anila Das Bandaranayake retired as Assistant Governor of the Central Bank of Sri Lanka in October 2007, having served for 24 years. In retirement, she pursues her personal and professional interests, particularly raising awareness on socio-economic and environmental issues for sustainable, equitable development in Sri Lanka. She has served on the Council, Open University of Sri Lanka, 2008 to 2011, on the board, Center for Poverty Analysis, 2014 to 2019, on the board, Federation of Environmental Organizations, 2021 to present, and as a member of the Delimitation Commission of Sri Lanka, 2015 to 2020 and 2023 to present. She holds a PhD in Statistics, Cornell, USA, MSc in Applied Statistics, Oxford, UK, and BSc First Class Honours in Mathematics, Columbia University, Sri Lanka. She began her professional career as a postdoctoral research fellow in Department of Biostatistics, Harvard University, USA. It is my pleasure to invite Dr. Anila Das Bandaranayake, our chief guest, to address the gathering.
How do I get this started? I'm a tech dinosaur. Somebody needs to help me to get this started. Thank you. Till then, good evening, everyone. Maybe I should stand up here. Maybe this. Oops. Oh, Nika. Okay. Patakan ගන්න පුළුවන්ද? මේකනේ? ඔව් මං කරන්න. පුළුවන් වෙයිනේ? ස්ක්‍රීන් එකේ එන්න තියනවා නේද? Right, thank you. Okay. Good evening, everyone. Before I begin, I would like to thank Dr. Arnold and Dr. Santushya Fernando, who liaised with me, and the College of Community Physicians of Sri Lanka for having invited me to speak to you this evening. I am a big fan of Sri Lanka's state health services, and in particular, the primary or preventive healthcare program. The manner in which you handled the COVID pandemic further strengthened my admiration. So for me, it is a great honor. You can see I'm not used to these gowns. For me, it is a great honor to be here today. In return, I would like to share with you from my discipline my ideas outside your medical comfort zone on this year's theme, Weathering the Economic Crisis Through Health System Efficiency. My topic for today is Facing Hard Truths in Hard Times, Optimizing Health System Efficacy in Sri Lanka. I will first share the hard truths and my views on why we now face these very hard times. I will then share my ideas on how your services can be optimized in this difficult situation. I usually set the development background to what I have to say. So if any of you heard me speak at the Colombo Medical Congress last November, please bear with me if a few initial slides look familiar. First, let me put our world in context. Sadly, material wealth and information technology are the new gods of humanity. Brainwashed to consume and acquire, many people live beyond their means. How did this happen? So post-World War II, in order for Western Europe and America to recover from the war, it was a consumption-led development model that was introduced that remains to this day, though I believe it has passed its use-by date. Resources then served 2.5 billion people's needs, and during the last 70 years, technology and populations have grown exponentially, and so have wants, because everybody, due to information technology, knows how the other half lives. At the same time, natural resources have, in terms of fresh water cover, forest cover, ozone layer, climate change, you know all of that. Natural resources have dwindled, and today our falling resources serve 8 billion people's wants, while global consumption continues to rise at a frightening level. At the same time, many people around the world have been lifted out of poverty. But having said that, the gap between the haves and the have-nots, as we all know, has widened, has gone up. This has resulted in frustration among the have-nots, leading to social unrest, intolerance, and violence. So in that context, and we see it not only in our country, but all over the world. In that context, there has been a huge paradigm shift in the development focus. Before, development globally was measured in terms of material well-being. The output of an economy in terms of gross domestic product, GDP, incomes of people, profits of companies, asset acquisition of both people and businesses. Now, it's very different because the world has realized that this is not enough. We are looking now at overall well-being, that is material, intellectual, and emotional, measured in terms of access to health, to nutrition, to education, to decent work, security and justice, and non-discrimination. And these are measured by very different indicators. Some are Human Development Index and the Sustainable Development Goals. We have happiness indices, corruption indices, law and order indices, all looking at the overall well-being of the human. So the development focus today has changed, and it's all about sustainable development to improve all 3 dimensions of people's overall well-being. And key targets today are no longer only material, they're about good physical and mental health, where you guys come in, adequate food security and nutrition, relevant education and skills development to enable people to achieve their individual potential, rewarding and gainful employment, where while enjoying what you do, you are also earning a wage that enables one to live a comfortable life. And countrywide access to all human beings to the above four: health, nutrition, education, and employment, while safeguarding environmental resources. And I think our crisis last year made it very clear that development is not about amassing material wealth. It is about people's lives and ensuring their well-being and their livelihoods while protecting our environment. So in that context, how has Sri Lanka performed? So I'm taking data from the last household income and expenditure survey of 2019, which was before the crisis, and before the COVID crisis and before the economic crisis. At that time, in terms of health and nutrition, the first two targets, Sri Lanka had about 9%, 2 million people who were food insecure. In my view, that is unacceptable in a country which has mostly arable land, plenty of water. 2 million people insecure. It was much worse last year, slowly getting better now. Employment, 14% were income poor, below the poverty line. And that means that their wages were inadequate to bring them above the poverty line. Then, in terms of access, there's a multidimensional poverty index, which measures, in addition to income poverty, access to health, education, etc. And 16% in our country had poor access to hospitals, to safe drinking water, to the closest bus stand, to the closest schools. And so if you look at it, 10 to 15% in a low-income country like Sri Lanka is quite good. However, when you look at district variations in deprivation, and I'm sure all of you who work in community health know this, the multidimensional poverty index had over 40% multidimensionally poor in one or more of those indicators in, I think it was Badulla, Nuwara Eliya, and Monaragala, and 6 districts had more than 25% multidimensional poverty, 1/4. In terms of food insecurity, 11 districts more than 10%, and over 20% in Vavuniya and Nuwara Eliya. So, but still, those are the hard facts. Now it has got worse, not too bad. How did we achieve this? As you all know, free health and education services and subsidies and social welfare programs for nutrition in the form of, we have had subsidized bread, subsidized basic food items, then subsidized utilities, electricity, water, what else? Diesel, petrol, gas, and even for livelihood, subsidized fertilizer, as well as low interest loans below the market rates for a number of livelihoods. And what has that led to? All these good freebies the government gave us. Physical and intellectual well-being, quite laudable, with high life expectancy, low infant mortality thanks to the health services. About 90% of our people live in their own homes, which are permanent, built of permanent materials. Almost 100% now have access to safe water, safe sanitation and electricity, and gender equality in education, among some of the good things in intellectual and material well-being. However, emotional well-being is not so good, especially for minorities in this country and for women, with high rates of domestic violence, justice not being meted out equally, and lot of problems with mental illness, which still has a stigma associated to it. And as I said earlier, high variations in well-being and low citizens' awareness of how these services are financed. Where does the money come from? So what has happened? Basically, a champagne diet is what Sri Lankans have lived on a kasippu income, and due to unrealistic expectations, because we want all those rights, right to free health, free education, subsidize this, subsidize that, with no responsibilities. Nobody, labor productivity in this country is very low, and nobody wants to pay taxes. Nobody wants to pay taxes, including the doctors and lawyers. So, tax avoidance is something that is very unrealistic, and as a result, successive governments, because they want to get your vote, they continue with unsustainable policies the country can't afford, and the outcomes are, when we think of free state health and education services, the return is very poor. Because in this country, you may already know, 70% of our women in the working age group do not work. Why? Because their wages are not enough for them to pay for child care, elderly care, disabled care. So they prefer to stay at home and attend to their family matters rather than go into the workforce. So the investment of the government in free health and education doesn't get a return in terms of productive employment in the country. Then the welfare programs are poorly or badly targeted. Now, my child went to a government school, he was given free school uniforms. I could afford to pay for uniforms, but I got it, untargeted uniforms. Then, if you look at multidimensional poverty, 16% of households, but Samruddhi was given to over 33%. Samruddhi is the most inefficient, useless program that the government has, and I'm hoping they're going to look at it because it really serves no purpose at all. Then utilities price below cost, what we discussed. And what happens? Electricity board, petroleum corporation, government railways, all running at huge losses. And who bears that cost? The government. A bloated, costly public sector. Far too many people doing far too little work. 1.5 million out of 8.5 million work in the public sector, almost. That's about almost 20%. And lot of freebies, free vehicles, what permits to get duty-free vehicles are provided, pensions are with hardly any contribution, it's all a freebie from the government. So Sri Lanka has basically lived beyond her means for decades, and we as citizens have unquestioningly accepted that successive governments borrowed and borrowed to satisfy our unrealistic expectations, till finally with a particularly bad government, we crashed last year. Not that any government has been good. Now the government is near bankrupt, entirely due to bad, unsustainable policies. So we have no choice now but to follow a very tough reform path. We have no money to repay our debt, and we are now struggling to get a debt recovery program in place. How then can the healthcare system improve efficiency? So first, let's look my limited knowledge of your area, though I'm a great fan of it. The preventive healthcare program, in terms of penetration, I know that every Grama Nilari division has your people working and supporting the community health. So the penetration is wonderful all around the country. There are public health inspectors, nurses, midwives, field officers, everybody. Then I'm fine, thank you. The coverage through your inoculation programs, the vaccination programs, the vitamins, folic acid for the pregnant mothers, then all the eradication programs, the coverage across the various subpopulations, non-communicable diseases, communicable diseases. Sri Lanka can proudly boast malaria is almost out, TB is almost out, leprosy is almost out, you all are handling dengue. So the characteristics, it is a very strong program. And the benefits, improve citizens' awareness, which then prevents illness. Preventing illness means that it reduces the pressure on the curative health services, the inpatients, outpatients, use of the operating theaters. So it reduces the potential pressure on the system. And of course, if you have people healthy and nourished, it will raise human productivity and output for the economy. So that is what we expect and what we get, but never can we remain satisfied with what we have done, because we have to always see how we can improve. We can only pat ourselves on the back whatever we do so much. So let's think about, in today's world, with all when you think about it, the sedentary lifestyles, because so many jobs are now sedentary. The fact that you are bombarded through social media with marketing for processed foods, for unhealthy fast foods, all kinds of, and then the stress, young family, young couples with children who are both working, the stress of that, then the pressure that's put on children by their parents to perform at exams, things like dementia, all kinds of issues, lots of new community health needs because of what I said earlier, the development model and the fact that the pace of life has increased. So what are the key, and I saw in what you all have done, you all have addressed some of these, so forgive me if I'm repeating what you all already know. Eradication of food insecurity. I mean, we should have zero food insecurity in this country. Why can't we do that? Then the aging, we are an aging population, so the same as you all have put a lot of focus on maternal and child health, I think now the time has come to expand services for geriatric care and geriatric health problems, including dementia. Then services for child, elderly, and disabled, what I mentioned earlier, those have to be looked at. Then another area, sex education and counseling in schools. We know the problems that are there. It's a very repressed society. There's a lot of unhealthy sex that children are subjected to through social media, and unless children are educated, you will have increases in rape, you'll have increases in unwanted pregnancies, and this is an area that really needs to be brought out into the open and addressed. And I heard that you all have been trying this for ages. You have to just push against all the opposition and get these things going. Then, as I said earlier, mental illnesses need to be addressed. There's far too few people to counsel at every age. And the eradication of domestic violence and substance abuse. And again, as I said, the reduction of poor nutrition and lifestyle-related NCDs, we have to work on that because diabetes, heart disease, and pressure are some things to worry about. And of course, teaching communities to protect their environment. So in that context, I would like to leave with you 3 areas that are completely outside of medicine on how, with the limited resources, you can improve efficiency. The first one is to optimize your allocation of your trained personnel, your MDs, your inspectors, nurses, all them. And for that, there needs to be a regular review of the system. And the reason I put this into my talk today is, when I was preparing for it, I asked for information on the category-wise numbers and the geographical distribution among your 340 MOH areas and among your primary healthcare units. And I was told that it would, I asked the association that it would take some time to get the numbers. I was surprised because actually, if you want to be efficient, you have, of course, my background is statistics and numbers, so I'm a little prejudiced in that direction. But you need to have the big picture. You need to have the big picture. So you need to know how many by category, how many by geographical distribution. In each district, divisional secretariat, how many of your people are there. Then rationalize the system. Personnel have to be assigned and services by sub-population demographics. So you need to know, as an obviously the more the number of people, the more the number of personnel required. But what personnel? You have to look at the age distribution, communicable, for example, an example. Let's look at climate. You know that in cold districts like Badul, Nuwara, Matale, the cold and the damp, there ought to be a higher degree of asthma and upper respiratory health conditions. So then, people trained in that should be put accordingly. Similarly, Polonnaruwa is supposed to have a kidney disease. The people who have to deal with that should be put there. So like that, you have to assign your personnel. First, know how many you need. Then address the shortages and the excesses. I'm sure it's a transferable service. And if there are gaps, do the training. So one area of improving efficiency is optimizing allocation by population size and population characteristics. Then next one is to strengthen collaboration with stakeholders. And I like to emphasize this because in Sri Lanka now, I've been retired for 15 years, I'm on various committees, and it's very frustrating because in Sri Lanka, everybody wants to hang on to their empires. They don't want to share information, they don't want to share credit for good things that are done. Who cares who gets the credit so long as the people benefit? So that has to be broken down. So one, and some examples. national administration system. Now, I already know, because I did a study of this when I was running something called the National Committee on Information for Evidence-Based Decision Making, that your MOH areas cut across administrative boundaries. You will have an MOH area, one GND, half in one MOH area, half in another, similar with DSS. So if your MOH areas cut across administrative boundaries, you can never, never, never find out the characteristics of the people in your MOH area. Why? Because it is only collected through the admin system. The Department of Census and Statistics uses the admin units to collect data. So if you ask for the population distribution in any GN, you can get it. But in an MOH area, if it crosses boundaries, you can't. So it is in your interest to make sure your MOH boundaries are adjusted so that they are either a group of GNs or a group of DSs, depending on the size of your MOH area, so that you can access population demographics for your areas of service. Second thing, collaboration with other state services. First of all, I'd say Department of Census and Statistics. They are the guys who have all the information on the demographics. Then through their surveys, they collect data on health, how much use of OPD, use of inpatient, what are the characteristics of NCD disease. They have those numbers. So if you want those, you have to go to either a census or a survey, which is done scientifically. And if you collaborate with Census Department, you will know when their new data come out so that you can access that. And when they are planning for new surveys, you can tell them, these are the questions we need answered for the community health program. Can you add these to your questionnaire? So that collaboration is important. Then with education, there are, with limited resources, you all are with limited resources, you can work with the MOHs can work with the education divisions to support school nutrition. Now, I heard, I was involved with a school nutrition program with private funding, and I heard that some areas, the government one funded by, I think, the World Bank or the WFP, was not successful, very poor quality. And I know the quality of the meals that our thing provided. So there is a need for public health inspectors and nurses to go and work with the schools to make sure that there is nutrition awareness, balanced food given. On drug abuse, I'm told that all over the country, not only urban areas, something called crystal meth is being used. Children need to know. And again, I'll emphasize the sex education. So work with the education department. Then with the police, because it is only the police who know the crimes related to alcohol, drug use, domestic abuse, and they are the ones who will know the numbers in the MOH areas. So you need to work with them as well to optimize collaboratively on the limited resources you have. And then finally with the private sector. Private sector has factories all over, and they want to have CSR where they can get brownie points. They want to be seen as the good guys. You can use that. Now, when I was on this school meal program, I went to a small school, 350 kids, dynamic teacher. Mind you, in the mid, she had 3 smart boards. She had a computer lab for her children with 12 computers extendable to 20. Why? Because she went and tapped the garment factory next door, and they provided everything. So the same thing if you want to set up daycare centers, creches, private sector companies, if approached, may be willing to build them, to equip them, or even to provide for the personnel. And there is a need to minimize the plastic waste and the pollution and work with the supermarkets in the areas to stop the use of plastic bags, because all that is affecting community health. And then finally, have I overdone my time? So last one, focus on current priorities. One, translate. I saw you all had been doing a lot of research to impact at the periphery. I know the health sector has been really good, but one example, I know I'm on a committee on food policy, and there are 70 institutions in agriculture that are supposed to be supporting agriculture. So many research institutes full of PhDs in agronomy and plant science, whatnot. And frankly, the farmer in this country has just gone from holding a mammoty to holding a hand tractor. He's always in debt by the time the paddy harvest comes in, and incomes are low. So all the research in the agriculture sector has not gone to the periphery. Please don't let that happen in health. Then the new challengers. Promote food substitutes. One example, last year price of rice went through the roof. No maize because of a silly policy to reduce fertilizer. Chicken and eggs have gone through the roof. But our people still want to eat 3 meals of rice a day when jack and breadfruit are rotting and falling off the trees. When you can grow more pulses like green gram to substitute for the animal protein, but nobody is thinking of that. You go to farmers' homes and there won't even be a, I know because I've been out in the field on work on surveys, you won't find vegetables. They will focus on the paddy. So you all need to push for food substitution within the community for people to know how to adjust to the prevailing times. As I said, mental illness, depression, oppression, counseling care, and monitoring the care centers, because you hear awful stories about hygiene and conditions in some of these elderly homes and disabled homes. Upgrade training to meet new needs, I saw that is happening, and lead by example on civic responsibilities. As a profession, you all should have zero tolerance on tax avoidance and rent seeking. I mean, the story out there is that many doctors, not many, some doctors take their fees in cash so they don't have to pay tax. That other doctors are in cahoots with the pharmaceutical companies to promote certain drugs. Now, no, I'm not saying any of it is true, but there is no smoke without fire. So if as a profession, you all are a very respected profession, if as a profession you want to push for change in this country to make sure governments no longer continue to borrow because they don't have to, because people are paying their taxes and people are not corrupt, then you need to push through your organizations. You know, strike off your membership. Any doctor who doesn't have a tax file, strike off your membership. Any doctor whose reputation is affected. You have to do something at this stage. We can't continue in this country to move forward unless we all work at it together. So I hope that I'll have some ideas. I'm known to shoot from the hip and say outrageous things. I hope you'll take it in the right spirit, and I hope there'll be some ideas that you can work on outside of the medical health, which you know more than me, so there's no point my talking about it, that will help you to work on your subject for this year, improving health system efficiency. Thank you.
Thank you, Madam, for that insightful outlook, for giving us a few hard truths and the tools, and also much food for thought for possibly the rest of the evening. We have now reached another important aspect of this evening, that is the College Oration 2023. For this, I would now like to invite Dr. S.M. Arnold, President of our college, to read the citation and present the medal for the orator of the College Oration, Professor A. Padmeswaran.
Arunasalam Padmeswaran had his primary education at Jaffna Hindu Tamil Mixed School, one of the best primary schools in Jaffna. He had his secondary education at two good schools in Jaffna, Jaffna Central College and St. John's College. Though he did reasonably well in school, as per Professor Padmeswaran, he did not excel in any particular subject or extracurricular activity. He was admitted to the Faculty of Medicine, University of Colombo in 1977 and obtained the MBBS degree in 1982. He prefers not to say anything more about his time at the Colombo Medical Faculty unless it is about the games of chess in the faculty common room. After internship and another year in Gaul, where he met his wife Sandhya, he went to the UK. From 1986, he worked in the NHS in various junior posts, in laboratory and clinical medicine for 5 years, including 1 year as a vocational trainee in general practice in South Wales, where his daughter Charuni was born. He rejoined the Ministry of Health as Medical Officer of Health, Walapane, in 1992. He obtained his MSc in 1994 and MD in Community Medicine in 1997. He joined the University of Kelaniya in 1995 as a lecturer in the Department of Community and Family Medicine, and in 2007 became a professor in public health. He retired last year after serving the University of Kelaniya for over 25 years. He teaches biostatistics, epidemiology, research methodology, and public health to both undergraduates and postgraduates. He is a regular contributor to research methodology workshop organized by the PGIM and the SLMA. He has supervised 20 doctoral research students. As a person well versed in quantitative research methods, he has participated in many collaborative research projects, resulting in over 100 publications in peer-reviewed journals. His diverse areas of interest included maternal and child health, medical education, non-communicable diseases, nutrition, substance abuse, and tropical diseases. He has served as a co-editor of the Ceylon Medical Journal. Professor Pathmeswaran believes that nothing should be left entirely in the hands of experts. I have great pleasure to invite Professor A. Pathmeswaran to deliver the oration.
Good evening, ladies and gentlemen. Thank you for your kind words, Mr. President. Madam Chief Guest, President of the College, members of the Council, fellows and members of the College, and distinguished invitees, ladies and gentlemen. I would like to start by thanking the President and the Council for inviting me to deliver the College oration this year. I feel humbled. As a founder member of the College, I am happy that at last I have made it to the stage of the inauguration ceremony. As many of you are aware, I have no particular research interest. I have not invested enough time and energy in any particular area to be recognized as an expert in anything. But I know a little bit about a few things. I decided to talk about universal health coverage, not because I consider myself an expert in this, but that is something close to my heart. So during this 30 minutes, I will try to answer these questions. That is, what is meant by universal health coverage, or at least what I understand by the term universal health coverage. What is the current status of universal health coverage in the country? What are our achievements? What are the challenges we have to overcome if we are to really achieve universal health coverage? And what can we do to achieve universal health coverage? I will not be answering each of these questions in turn, but I hope by the end of the next 30 minutes, you will have your own answers to these questions and many other unanswered questions of your own. In fact, I will feel that I have done a good job if you have many unanswered questions by the time I finish. I may take a few detours, but these will be relevant to better understand the problems we face. Universal health coverage means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. It covers the full continuum of essential health services from health promotion to prevention, treatment, rehabilitation, palliative care across the life course. The picture I have shown is a schematic representation relating the available funding to the current status of universal health coverage. This is not specifically about Sri Lanka, but a generic representation. We obviously have some way to go to reach universal health coverage. This figure highlights the gaps in 3 dimensions. The extent of population covered is less than 100%. The cost met by the public is more than 0%. And services covered is less than 100%. What we want is 100%, 0%, and 100%. Theoretically, everyone is covered for all the services in Sri Lanka, but there could be a significant component of out-of-pocket expenses. The reality is that there are imbalances in the geographic distribution of services. Whether a person is able to travel the necessary distance to access the required services depends on his or her socioeconomic circumstances. Can we really afford to provide the full range of quality services they need? Or for that matter, can any country or society afford to do that? The short answer is no, it is not possible. But if you look at Sri Lanka, our chief guest already alluded to some of this, our indicators are very good. Our infant mortality rate is 10.1 per 1,000 live births. Our under 5 mortality rate is 12 per 1,000 live births. The maternal mortality rate is less than 30 per 100,000 live births. And our life expectancy is really good. Females 78 years and males 72 years. Some of you may argue that these are not the best indicators or that these do not give the full picture. There may be some truth in that, but we'll just stick to these 4 for the time being. These are all very good, much better than what they were 75 years ago when we became an independent nation. But these are average figures, and average figures can always hide variation. Right? There is some regional variation, and we know that the people living in the estate sector have poorer health than others. We do not routinely collect or disseminate data on variations in health status by either socioeconomic status or race and stuff like that. Therefore, there is no way of knowing the extent of inequities in health using routinely collected data in our country. But how accurate are these numbers? We believe that these health indicators are calculated using good quality data, but we have problems. One would think that the infant mortality rate is a relatively easy thing to calculate. We need the number of infant deaths during the year and the total number of live births during the year. And we have 2 good sources at the grassroots level registering and reporting births as well as infant deaths, the public health midwives and the registrars of births and deaths. Unfortunately, their numbers don't tally. So if you look at these numbers, these are for the year 2015. That's the latest available from the Registrar General, so I am comparing that with the 2015 numbers from the midwives. Right? The infant mortality rate reported by the midwives works out to 9.2 per 1,000 live births. By the registrars, it's 7.5. I mean, it looks like a small difference, 1.8 per 1,000 live births. But is this difference really small? No, it works out to a discrepancy of 38,000 births or 10% of births, or 900 infant deaths or 25% of infant deaths. I am sure there are some good explanations for these discrepancies, and some of you may be working to reduce or eliminate these discrepancies. I highlighted this at this point because there will be some more numbers, and we should be careful when we are interpreting numbers. Numbers put up on good-looking slides or in laser-printed outputs look good, and we tend to believe it. But we should always think of can be believed. I mean, my standard starting point is I don't believe anything, right? Right, but it's a good start to look at the definition of health, right? Health is defined as a state of complete physical, mental, it's boring, I mean, you have seen this so many times, but well-being, and not merely the absence of disease or infirmity. This is a good definition because it positively frames health. What I don't like about it is the word complete. I mean, I am not complete, but I would like to say I am healthy, right? But the next bit is the one that I like most, right? The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social. I mean, that bit is not relevant. It's the fundamental right of every human being. So what does it mean when we say that something is a fundamental human right? I believe that one of the main responsibilities of the state or government is ensuring the protection of the fundamental rights of its citizens. We could say that people should take responsibility for their health, but the state should ensure that the environment, social, economic, and physical, is conducive and the people are empowered to ensure good health. In my opinion, health is not for being productive or for being instrumental for anything else, because that is the natural state of human being. We should be healthy because that's the done thing, right? So our indicators are better than or as good as most countries in the region or countries in a similar stage of economic development. It is difficult to pinpoint exactly the factors contributing to this achievement, but there is general agreement that factors such as a free health service, the health unit systems from 1920s, free education from 1940s, and welfare measures since independence, various welfare measures. I don't think any of these interventions were either costed or piloted. They were implemented because someone thought that was the right thing to do, or because it was politically expedient. I am a strong believer in unintended consequences, and unintended consequences need not be always bad. Unintended consequences can be good, right? So these people did it without knowing what they were doing some of the time, but we got to where we are now, right? And I mean, some of these elements are actual primary health care, even before, well before it was articulated in Alma Ata in the declaration in 1978. Our health system had elements of primary health care. So this declaration of primary health care, sorry, this is also boring, right? It says primary health care is essential health care based on practical, scientifically sound, and socially accepted methods and technology made universally accessible to individuals and families and communities. The next bit is important because of what our chief guest said, what the country can afford, right? So primary health care is not a uniform thing that is a universal thing for all countries. It's the same thing, right? It depends on what you can afford and but we didn't do it that way, right? And in the spirit of self-reliance and self-determination, I haven't highlighted self-determination because that's a dirty word in our country, right? But we could have avoided a lot of confusion if they stopped at this stage when talking about primary health care. But you can't keep anything brief when it is being drafted by a high-powered committee, right? So the next bit comes on to say that it is integral part of, for me, primary health care is everything. The whole, whatever the Director General of Health does is primary health care, right? But then they make it confusing by saying there is something else other than primary health care, and first level of contact is primary health care. First level of contact is primary care, right? And so it becomes confusing, and so we'll stop at that. But for a country where everyone is in favor of strengthening primary health care, we don't appear to be spending much on primary health care. So if you look at our numbers, spending on primary health care, these are from some international database. I just copied it, not the graph, the numbers, right? Graph, I made it, right? Thailand spends 62% of health expenditure on primary health care. India spends 55%, 59%, but we are spending only 22%. But one should be careful in interpreting this percentage of healthcare spending on primary healthcare. A high percentage of healthcare spending on primary healthcare may be due to either a real emphasis on primary healthcare, as in Thailand, or a reflection of neglect of non-primary healthcare services. Any proportion can be made high by either increasing the numerator or decreasing the denominator. A low percentage of the health expenditure spent on primary health care alone cannot be considered evidence of misplaced priorities. A low spending on primary health care can be a problem only if the absolute amount spent on primary health care is inadequate. So are we spending enough? There is inadequate money for health, and then there is inadequate health for the available money. And we already have this problem of inadequate data, I will come to that, and maldistribution of resources. Half of what I have, the chief guest has already said it, but this happens to me wherever I go. Right. This brings us to the question of overall healthcare spending. So health expenditure in the US is 18.8%. That is way off the top, right? Of the percentage of GDP. For the lack of any better comparisons, we'll just compare it with the GDP. And the US spends 18.8% of its GDP on healthcare. The UK spends 12%. And that is probably the par value because most of the developed countries spend about 10 to 12%. So it looks like our 4% is low, but it's not that low because Thailand spends only 4.4% and they are, I mean, what we achieved in health was by accident, and Thailand has achieved all that by planning and imitating what we have done in the past, right? They costed their programs and they have done it, right? So Thailand is spending only 4.4%, so 4.1 shouldn't be too low. It is true that in general, people living in countries that spend more on health are healthier, but it's not an absolute truth. I hope you can see it because this is the only graph I just picked from somebody else, right? And life expectancy and per capita health expenditure. Now on the extreme right is the United States. Even though they are spending a lot, they are not at the top, right? And the two lines I have drawn indicate that there is a lot of variation, right? So say, if you look at the vertical line, it shows the variation in life expectancy for the same income, the per capita health expenditure. And you can also see in the horizontal green line, variation in per capita health expenditure in terms of for the same life expectancy, right? So even though there is a general trend, there is a lot of other things going on that determine life expectancy. But what we have to remember is that our healthcare budget is unlikely to increase in the near future. But the expenses will increase due to the inherent nature of healthcare costs. Medicines, devices, and salaries, they keep on increasing. And in addition to that, aging population and increasing incidence of non-communicable diseases will increase our healthcare cost. There is universal agreement that people should not be paying for healthcare as and when they need care using their own funds. Healthcare expenses can be very high in some situations, and only a minority of people in any society will be able to meet these costs using their private funds. This situation calls for a solution where the risk is spread among as many people as possible. A general taxation-based system, as in Sri Lanka, ensures that risk is spread among the most number of people as possible. So what can we do? We can continue the status quo. The privileged get better access, and for the others, it's a lottery. If you are lucky, you get access to world-class treatment in our public sector hospitals free of charge, but not everybody gets it. Right? Or we can spend the money we have more efficiently. But we don't use data enough to make rational decisions, right? We need appropriate data if we are to identify our problems and take remedial action. We learn about the AAA cycle, assess, act, analyze, and there are now newer versions of this with some other acronyms. AAA was there when I did my courses 30, 40 years ago, right? But in many instances, monitoring and evaluation appear to be afterthoughts rather than being built into projects from the planning stage. Often the required data is missing, or there is a delay in processing the data. The available data is not disaggregated by age, sex, or social class. So these are issues with the data we have, and this is when I try to make my slides, the problems I went into. Right? I mean, we can't get even the names of our district spelled consistently in a publication. Right? I mean, many people can't spell my name, but that doesn't matter. Right? But there are only 25, or we have made it 26. We don't know exactly how many districts we have, right? And we can't spell them. So I detected these issues with the spelling as I tried to extract the data from different tables in the annual health bulletin programmatically to merge the different tables to analyze the geographic distribution of resources. Right? So what did I find? I managed to do it. Right? So I looked at facilities, manpower, skill mix, such things, how we are doing. Right? So this is what I found. So what I have done is I have the health bulletin has the whole set, but I have just put the top 3 districts and the bottom 3 districts in terms of hospital beds. Now in a country where we say that we have 4 beds per 1,000 people, the difference between the top and the bottom seems high. Right? But I mean, there are 2 districts, Mana and Mullaitivu, being very high. It's probably a result of what the rebuilding operations after 2009, right? But I'm not sure why Gampaha and Kalutura are at the bottom. Is it a real thing, or whether there is some issue with the data? I don't know. I haven't looked into this. But if we ignore Mana district, the difference between the best and the worst is just a 2-fold difference, 5.8 versus 2.5. And if you look at nurses, the picture is different. We have an average of 1.6 nurses per 1,000 population, but there is a 3- or 4-fold difference between the top and bottom. I mean, Colombo does well because, I mean, all our infrastructure is in Colombo, so I don't think anybody should find fault with Colombo having good numbers. We are also in Colombo, right? But if you look at now nurses, it is the 3 bottom districts are unpopular districts, right? And I looked at pharmacists also, a rare breed in our country, right? So I had to make it per 10,000 population, otherwise it will be a very small decimal number, right? Colombo has many, but Kalutura Kurunegala. So this Kalutura Kurunegala, I think somebody should look at the data. I don't believe that they are that bad. And the medical laboratory technicians are also like that, right? Kilinochi Nuvaraliya, they aren't. So this data shows that it is possible to build and equip hospitals almost anywhere. But sending trained staff to difficult areas is not easy. It is good to look at the trends in the increase in the different categories of staff to see whether we have taken steps to develop adequate human resources for health. So I just looked at a few. So the earliest numbers I had was for 1992, and the latest is for 2020. There is a huge increase in doctors. Right? The rate per 100,000 was 19.2 in 1992, and it has become 97.9, almost 1 doctor per 1,000 population we have now. Nurses, yes, reasonable increase, 3.3 times when you compare with the past. And the public health inspectors and public health midwives, public health midwives, there is almost no change, right? The public health inspectors, but probably the public health midwives, the rates being not changed is rational or appropriate, because I don't think over the last 30 years there had been any major shifts in the number of births in the country. The birth rates has come down, but number of women in the age group has gone up, and so the numbers are okay. But public health inspectors not increasing is a problem, because they are dealing with an increasing variety of problems related to food hygiene, control of communicable diseases, environmental issues, and now even things like the NATA Act and the cigarettes and things, they are involved. And I don't think there is enough. Right, now these are a bit tricky things. What are the impediments to innovation? We have, in some cases, we either have prolonged incubation or we have premature rollout of projects. Right? And then there is vested interest and infighting. I will not go into that. This is something I came across accidentally about the primary healthcare system strengthening project. By the people who are running the project, they have published this. So it's internal assessment. But there are some serious deficiencies. I think some of the authors are also here. Staffing inadequate numbers in all categories other than doctors and nurses. But majority of doctors and nurses had not received specific training regarding the project. Medicines, almost 40% of essential medicines not available. They have put it as 60% available. Right? And even the medicines that were available, there was a lack of buffer stock of many of the available ones. None of the dispensaries or pharmacies were air conditioned. I think we have a law now, some regulation that says all private retail pharmacies should be air conditioned. But our hospital, this is in a pilot project area, right? So I can't imagine how it will be in other areas. The laboratory support, several basic tests were not available. Either machines were available. If the machines were available, there was no space to install the machine. If you install the machine, there was no MLT to operate the machine. Right. Then there was a problem with the information system. Not enough trained data entry operators. The web-based system had poor connectivity and inadequate server speed or capacity. I don't think in this 21st century, we should have data entry operators. Anybody who generates data should enter it, and the people who expect them to generate the data should give them the devices that will work as data entry stations. There is no need for a doctor or a pharmacist to do paperwork and then somebody else to enter it, right? These data entry operators should not be encouraged. So this is the situation in a well-funded project, right? Under these circumstances, it is difficult to imagine how empanelling, which is part of this project, can succeed when it is implemented throughout the country. But this brings me to the question of choosing our words. we should choose our words carefully if we want the public to accept empanelling. Empanelling is where you register. The way I have understood is people have to register with a primary care provider and then, right? And the reason we are doing it is we want to stop bypass, right? But we shouldn't tell this to the people. One reason for the success of the maternal and child health program is that families were registered with the area public health midwife and through her with the local medical officer of health. The midwife and the medical officer of health are responsible for maternal and child health. Right? Because of this system, there was a very good follow-up and everything was done well. I suggest that we should not promote empanelling as a way to stop bypassing, but as a system to ensure that everyone receives appropriate level of care, irrespective of whether they live near a tertiary care hospital or not. The doctors running the first contact hospitals should function as advocates for the patients registered with them rather than gatekeepers to the healthcare system. Gatekeepers are used to restrict access, and Sri Lankans know how to bypass gatekeepers. Then there is this premature rollout. I had a peripheral interest in this project and strengthening of primary level care management of non-communicable diseases program. It was implemented very nicely. There was data collection, there was assessment, baseline assessment. But what happened? Nationwide introduction of healthy lifestyle centers and or clinics along the lines of the pilot project was implemented before the results of the pilot project were available and we could do anything about it. I think I will skip this. I want to be safe, right? Right, so how do we get more health for available money? We should reduce waste and improve quality. I mean, reducing waste and improving quality are two sides of the same coin, right? And we must determine the cost effectiveness of new interventions, new medicines, new procedures, or even new programs before introducing new services. But is it possible to include equity considerations into your cost effectiveness calculations? I think that is important. And determine the cost effectiveness of existing services. We may have to discontinue some of them. I mean, it is known that at times we have purchased and used in our government hospitals new cancer drugs that were not available even in the NHS in the UK. This champagne and kasipu is, I think, apt for Sri Lanka. So how do we achieve universal health coverage? The three key questions to be answered are these: who is covered, what proportion of the cost is covered, which services are covered. Answering these three questions is not easy if we start with a clean slate. We can appoint task forces and seek the help of expert consultants to answer these questions. But if we stop and remind ourselves about our commitment to primary health care, we will realize that we have already answered the first two questions. Answer to the question who is covered: everyone is covered irrespective of their ability to pay. Some clever people may tell us that we need not provide free services to the rich people as they can afford to pay for their services either out of pocket or through private insurance. The rich people might say that by opting out of the free health service, they are doing a service to the community. There will be less number of people using the limited services. The problem with this approach is that we will end up with two healthcare systems, one for the poor and one for the rich. It is widely believed that systems designed for the poor become poor systems. So how can the rich ensure that everyone, including the poor, have access to quality health care? Easy. By paying taxes. By paying taxes, all of us contribute to a publicly funded healthcare system. What proportion of the cost is to be covered? I mean, there are people who talk about user fees and rate. But it has to be 100% if we are concerned about equity. Any system that requires people to prove that they are not able to meet even part of the cost of accessing the healthcare system can be considered as a barrier. These barriers could even exclude the poor from the healthcare system. Okay, I will try to finish quickly. Now, we are looking at technical solutions. If you ask an epidemiologist, he will say, we need better assessment and prediction about disease burden. A health economist would come up with innovative solutions to increase funding for healthcare. A human resources for health expert would recommend ideal skill mix required to meet the challenges of an aging population and increasing burden of non-communicable diseases. A quality improvement expert would introduce interventions to reduce waste. These are all essential interventions, but they are not sufficient to achieve universal health coverage. Eventually, it's a political solution. Rudolf Virchow, who was not really a public health man, he was a pathologist. Right? He said that more than a century ago, that medicine is a social science and politics nothing but medicine at a larger scale. The idea of a ladder of political activism, as put forward by Meckenberg in 2009, is very relevant today for our young community physicians. It is a ladder with 4 steps. The first or the lowest step of the ladder is political pessimism. Like me, limit interactions to within the scientific community, speak to politicians only if they ask for advice. Most of us are probably in this category. The second step of the ladder is to disseminate information actively, write reports to the government or targeting politicians, and actively use mass media or even social media. Many young and not so young members of our college do this. The third step involves lobbying and actively influencing politicians. Our college and organizations like the SLMA, as well as many senior members of the profession, do this. The fourth or the ultimate step is to become a politician like Salvador Allende, who was the president of Chile. A couple of past presidents of our college have taken the plunge, and they are in the audience now. So what I can say is we have to accept that we cannot afford universal health coverage if we define it as all people have access to the full range of quality healthcare services they need without financial hardship. In order to move forward, we must agree on the full range of services or essential services that will be available to all without financial hardship. This is not something to be decided upon by experts behind closed doors. This has to be decided upon with the full participation of a well-informed public. I know this sounds idealistic and utopian, but we should not always settle for what is practical. We should be prepared to do what is right. Right, I should now end by thanking a few people. I think the first person I want to thank is the first person who supervised a research project by me was Professor Diyanath Samarasinghe. What I learned from him, or what he made me realize, was that doing research is fun. Then I should also thank my other supervisor who supervised my MD with great difficulty. And she taught me, Professor Kumudhu Vijayavardhana, that I should say what I mean. Or did she say that I should mean what I say? That's what I learned from her. Then I have spent 25 years or more than 25 years of my life at Ragama and in the Department of Public Health. So all my colleagues at Ragama, I was made to feel at home. Right? I mean, my wife was not very happy, but I was made to feel at home at Ragama, and it was nice. And the faculty, the rest of the faculty, for their friendship and companionship. Who else? Yeah. And the three women in my life, my mother, my wife, and my daughter, who by encouragement, criticism, suggestions, and being there always for me, and I'm happy. And thank you all for your efforts. Thank you.
Thank you and congratulations, Professor Padmeswaran, on the college oration. And you will be happy to know that I'm sure, as I do, all the audience have a lot of unanswered questions after the oration. And thank you once again for that insightful and interesting outlook of universal health coverage in Sri Lanka. To be awarded a fellowship of the College of Community Physicians of Sri Lanka is indeed a prestigious and momentous event. And we have now reached that point of the evening. I would now like to call upon Dr. Shiromi Madhuage and Dr. Santusha Fernando to read the citations of the members of the college who will be receiving fellowships this evening. And I would like to call upon our president, Dr. S.M. Arnold, to present the awards to the fellows.
I'm privileged and deeply honored to introduce Dr. Don Sudat Dharmapriya Samaravira for the fellowship of the prestigious College of Community Physicians of Sri Lanka. Dr. Sudat Samaravira completed his master's degree and doctoral degree in community medicine in 1997 and 2004, respectively. He completed his PhD at King's College, London. Dr. Samaravira has authored several peer-reviewed research publications, over 45 published abstracts locally and internationally. He is an editor-in-chief of the Sri Lanka Journal of Health Research. He has organized several local, international symposia, including National Health Research Symposium, National Symposium on Best Practices for Innovations on Cancer Prevention, Control, and Palliative Care in 2018. He has contributed to develop several guidelines, training manuals, and strategic plans for tuberculosis, TB, HIV, co-infection, cancer, palliative care, dengue, and research governance. He also pioneered the organization of comprehensive external program evaluation in the National Tuberculosis Program and the National Cancer Control Program. Dr. Samaravira is currently serving as a consultant to the WHO on prevention and control of dengue and other arboviral diseases in Southeast Asia region. Dr. Samaravira is a member of the CCPSL since 2003 and a member of an editorial committee of the Journal of the College of Community Physicians of Sri Lanka since 2016. President, sir, considering the great contribution made to the field of public health, I present to you Dr. Don Sudat Dharmapriya Samaravira for the conferment of the fellowship of the College of Community Physicians of Sri Lanka for the year 2023.
I'm privileged and deeply honored to introduce Dr. Indrani Priyadarshini Samarasinghe for the fellowship of the prestigious College of Community Physicians of Sri Lanka. Dr. Priyadarshini Samarasinghe started her career in public health working as a medical officer attached to the anti-leprosy campaign and the Medical Officer of Health Mahara. She completed her MSc in Community Medicine in 1995 and MD in Community Medicine in the year 2007. She has immensely contributed in conducting an island-wide study on illness experience and socio-cultural meaning of leprosy and monitoring of leprosy elimination activities. While working as a visiting fellow at the School of Population Health, University of Melbourne, Australia, she served as an investigator to the Tasmanian longitudinal health study regarding associations between women's reproductive history. She has worked as a consultant community physician, planning at the Office of Provincial Director of Health Services of Western Province, at the National Program for Tuberculosis Control and Chest Diseases, and worked as the acting director of the Anti-Filariasis campaign. She has given her contributions for several noteworthy projects, National Drug Resistance Survey in 2017, and several tuberculosis-related publications. Dr. Samarasinghe has been a member of the CCPSL since 2000 and was a council member in 2017-2018 and a member of the JCCPSL editorial board from 2009 to 2022. President Sir, considering the great contributions made to the field of public health, I present to you Dr. Indrani Priyadarshini Samarasinghe for the conferment of the Fellowship of the College of Community Physicians of Sri Lanka for the year 2023. Madam.
I am privileged and deeply honored to introduce Professor Lokumigodage Don Jude Upul Senarath for the fellowship of the prestigious College of Community Physicians of Sri Lanka. Professor Upul Senarath commenced his career in public health as a medical officer of health. He completed his master's and doctoral degrees in community medicine in 2001 and 2004, respectively. He joined the Faculty of Medicine, University of Colombo. He was promoted to professor in 2012 and as a chief professor of community medicine in 2021. Professor Senarath served as a secretary of the Board of Study Community Medicine of PGIM 2009 to 2012, chairperson of the community stream of Faculty of Medicine, University of Colombo from 2015 to 2019, and the convener of the Rural Health Research Center, Kataragama. Presently, he is the head of the Department of Community Medicine, Faculty of Medicine, University of Colombo. Professor Senarath has published over 85 peer-reviewed journal articles and holds a PhD in Public Health Nutrition. He delivered the CCPSL oration in 2012. He was awarded the University of Colombo Excellence in Research and Presidential Awards. He has been technical advisor to the Ministry of Health and consultant to several UN organizations. He is also the co-founder of the South Asian Infant Feeding Research Network. Professor Senarath has been a CCPSL member since 2002, and he was an editor and a council member to the CCPSL. President Sir, considering the great contribution made to the field of public health, I present to you Professor Lokumigodage Don Jude Upul Senrath for the conferment of the Fellowship of the College of Community Physicians of Sri Lanka for the year 2023.
I'm deeply privileged and honored to introduce Dr. Palitha Karunapema for the Fellowship of the prestigious College of Community Physicians of Sri Lanka. Dr. Palitha Karunapema started his career in public health in 2001 as the Medical Officer of Health, Dompe. He obtained his Master's in Community Medicine in 2005 and MD in Community Medicine in 2007. He worked as a consultant community physician to the Non-Communicable Disease Unit, Ministry of Health, and he has undertaken a leading role in the formulation of national policy, strategic framework for prevention and control of chronic non-communicable diseases. As the chair of the NCD subcommittee of the SLMA, he contributed immensely to the Nirogi Lanka project as well. As the director of the Quarantine Unit, Ministry of Health, he conducted the WHO-IHR Joint External Evaluation in 2017 and developed the National Action Plan for Health Security, resulting in Sri Lanka to be the first country in the region to carry out this important task. While working as the director of the Health Promotion Bureau, he contributed to convert traditional health communication modalities into digital platforms. Dr. Karunapema currently holds the position of Director, Health Information, and contributed to establish the COVID-19 surveillance digital platform and a nationwide implementation of the vaccine tracker and that provides leadership in developing the National Digital Health Architecture Blueprint. Internationally, he has worked as an expert supported by several countries to conduct the WHO-IHR Joint External Evaluation and is a member of the advisory panel of the WHO-IHR COVID-19 Emergency Committee. He is the current chairperson of the Board of Study of Community Medicine and Community Dentistry. He has served as a council member of CCPSL for 5 years. President, sir, considering the great contribution made to the field of public health, I present to you Dr. Palitha Karunapema for the conferment of the Fellowship of the College of Community Physicians of Sri Lanka for the year 2023. Dr. Karunapema, ladies and gentlemen.
I'm privileged and deeply honored to introduce Dr. Imbulana Liyanage Kapilesiri Jayaratne for the Fellowship of the prestigious College of Community Physicians of Sri Lanka. Dr. Kapila Jayaratne started his public health career as the Medical Officer of Health, Biyagama. He obtained his MSc and MD Community Medicine in 2005 and 2007 respectively. As the National Program Manager for the Maternal and Child Morbidity and Mortality Surveillance attached to the Family Health Bureau, he improved the maternal death surveillance system, which is recognized as a role model at the global level. He pioneered establishment of surveillance system for maternal near misses, maternal suicides, infant and child deaths, birth defects, and pathological postmortem. He modeled an ergonomically compatible school bag and launched the National Healthy School Bag campaign. He was the media coordinator to the CCPSL during COVID-19 pandemic. He served as a director in the Presidential Task Force to prevent COVID-19 among the Tri-Forces. Dr. Jayaratna is a member of the WHO Technical Group on Burden of Birth Defects, Maternal Mortality, and Cause of Death Estimation. Dr. Kapila Jayaratna has contributed to serve WHO publications. He has also been a member of Stillbirth Advocacy Working Group, International Stillbirth Association, and International Ergonomic Association. Dr. Kapila Jayaratna is a member of the CCPSL since 2005, council member since 2009, and he was the treasurer of the CCPSL during 2021-2022. Dr. Jayaratna has served in the several subcommittees of the CCPSL, including media, and he was awarded the Honorable Fellowship by the Obstetrics and Gynecological Society of the UK. And President Sir, considering the great contribution made to the field of public health, I present to you Dr. Imbulana Liyanage Kapilasiri Jayaratna for the conferment of the Fellowship of the College of Community Physicians of Sri Lanka for the year 2023.
This is the final fellowship awarded tonight. I am privileged and deeply honored to introduce to you Dr. R. Kesavan for the fellowship of the prestigious College of Community Physicians of Sri Lanka. Dr. Kesavan obtained his MBBS degree from the University of Jaffna and subsequently received his MSc in Community Medicine in 1999 and the MD in Community Medicine in 2009. He is a Fellow of the Royal Society of Public Health, UK. He worked as a provincial epidemiologist and provincial consultant community physician. Dr. Kesavan has worked in WHO Southeast Asian Regional Office and the WHO Country Office of Sri Lanka, the Philippines, and Liberia. He has published several research articles in peer-reviewed journals and has been a reviewer for more than 20 international journals and is an editor of the Central African Journal of Public Health since 2022. Dr. Kesavan has also been a visiting academic in 4 national and international universities. He has been a CCPSL Council member in 1999-2000 and was the president of the Northern Chapter in 2021-2022. President, Sir, considering the great contributions made to the field of public health, I present to you Dr. R. Kesavan for the conferment of the Fellowship of the College of Community Physicians of Sri Lanka for the year 2023. Dr. Kesavan.
Thank you, sir, and congratulations to all our fellowship awardees. The College of Community Physicians of Sri Lanka would now like to take the opportunity to commend and appreciate the postgraduate students who have had the highest performance in community medicine in the year 2022. Therefore, to give the awards for the best performance in community medicine, MSc and MD, I would now like to invite once again Dr. S.M. Arnold, President of the College of Community Physicians. The award in recognition of the highest academic performance at the MD Theory Community Medicine 2022 is awarded to Dr. Aruni Oshadi Polwatta Gallage. Ladies and gentlemen, Dr. Aruni Oshadi Povattagalage. The award in recognition of the highest academic performance at the MSc Community Medicine 2022 is awarded to Dr. Chiranti Nadisha Thanasinghe. Once again, ladies and gentlemen, Dr. Chiranti Nadisha Thanasinghe. Thank you, sir. We have now reached the end of a very interesting evening, and in order to complete the official proceedings, I would like to invite Dr. Tushani Dabrera, Secretary of the College of Community Physicians of Sri Lanka, to propose the vote of thanks.
Thank you, Nimani, for your kind introduction. Good evening. President of the College of Community Physicians of Sri Lanka, orator tonight, Professor Padmeswaran, council members, past presidents, fellows of the College of Community Physicians of Sri Lanka, our chief guest, Dr. Anila Dias Bandarnayaka, former Assistant Governor of Central Bank of Sri Lanka, Dr. Asela Gunawardena, Director General of Health Services, and all the officials from the Ministry of Health, other ministries, UN agencies, academia, professional colleges, ladies and gentlemen. It is with immense gratitude and a deep sense of honor that I stand before you to deliver the vote of thanks at the inaugural ceremony of the 28th Annual Academic Sessions of the College of Community Physicians of Sri Lanka. I would like to begin by expressing our sincere appreciation to Professor Arunasalam Padmeswaran for gracing this occasion with his eloquent oration. Sir, your insightful words have enlightened us and set the tone for a thought-provoking and a productive academic session. To the esteemed council members, past presidents, and fellows of the College of Community Physicians of Sri Lanka, we owe a debt of gratitude for your unwavering commitment and dedication to the advancement of community medicine. Your vision and leadership have been instrumental in guiding us towards excellence. A special word of thanks goes out to our distinguished chief guest, Dr. Anila Dias Bandarnayaka, former Assistant Governor of the Central Bank of Sri Lanka. Your presence here today has added immense value to this event, and we are honored to have you share your wisdom with us. We are deeply grateful to Dr. Asela Gunawardena, Director General of Health Services, all the officials from the Ministry of Health and other ministries, UN agencies, donors, academia, and professional colleges who have taken the time to join us today. Your support and collaboration are crucial in shaping the future of community medicine in Sri Lanka. A special note of thanks to Dr. Nimali Danrol for serving as the convener and ensuring the smooth flow of the ceremony. Our special thanks to the Director PGIM and the management for the support given to conduct the sessions. Thank you, Mr. Tushara Vidanagama, our college assistant, for the support rendered throughout. Special thanks to Mr. Nilanga and the AV team and Mr. Lahiru, the photographer. Last but not least, I would like to express our gratitude to the entire organizing committee and all the volunteers who have worked tirelessly to make this event a success. To all the attendees, thank you for joining with us tonight to witness this momentous occasion. Your participation has made this event even more meaningful. With that, I invite each one of you to join us for the reception, where we can continue to network and share ideas and wishing you all a very pleasant evening. Thank you very much.
Once again, ladies and gentlemen, thank you for being with us this evening. We hope you had a pleasant evening, and we hope you will join us for the reception at the 3rd floor. So have a pleasant evening and good night. Please rise for the ceremonial procession. Thank you, ladies and gentlemen. And just another kind reminder that the reception is at the 3rd floor of this building. Thank you and good night.